So I'm going to talk about, in a few brief minutes here, to try and talk about inpatient rehab and the transition to home and outpatient rehab. So, we all know that AFM strikes very suddenly and can have any ranging from a mild to a very severe impact on a child's health and physical function. And in addition to the effect that it has on the child, it can have a profound psychosocial impact on the entire family. So in order for a child to be able to participate to their fullest extent in intensive inpatient rehabilitation, we need to make sure that we have them on a unit that has a large multidisciplinary team that can deal with all the medical and psychosocial issues that will affect the child's ability to do rehab. So on the inpatient unit, the goals for inpatient rehab include short-term goals to facilitate the developmentally appropriate functional independence and the use of compensatory devices as needed, while simultaneously working on long-term goals for recovery of function and mitigation of long-term consequences. We also want to provide support, psychosocial support and education to the child, the caregiver, and the siblings. And then in the absence of as clear, a full recovery, we may need to make recommendations for potential surgical interventions or advanced technologies that could help to improve independence. So the medical issues that the team will need to deal with, Dr. Edmondson already touched on, and so I won't go through all of that again. I'll just talk about how, if they aren't well managed, they can interfere with rehab. So if we aren't treating pain well, children will have difficulty. The therapist will have difficulty handling the children, touching them and trying to do range of motion, which could lead to joint contractures if that's not well managed. The biggest issue that we usually have affecting rehab is hypotension, orthostatic hypotension in the more severely involved children, which can lead to difficulty getting to a standing position. Bowel and bladder dysfunction, while it's uncommon, it does occur in some of the most severely affected children, and it is a lower motor neuron pattern. They have urinary retention and difficulty initiating voids, and they also have slow transit constipation, which can lead to incontinence. So if we don't manage a bowel program well, it can lead to frequent interruptions in therapy for cleanups and changes. Respiratory issues range from atrophy of accessory muscles to inability to cough, to tracheostomy, to ventilator dependence. And this leads to difficulty with communication with the therapist. It can lead to interruptions because children need frequent suctioning. And then we need to be cautious that ventilator weaning, at least when we begin with, doesn't interfere with the child's ability to do therapy. Some children present with dysphagia if they have cranial nerve involvement requiring tube feedings. Many children, no matter what their severity is, have a decreased appetite, parents report to me, and this could all be exaggerated by constipation. So kids having poor oral intake and food refusals can be irritable in therapy if they're hungry and not eating well. Hypercalcemia immobility has been seen, and we've seen that children lose bone density very quickly, which can result in fragility fractures. We don't limit any rehabilitation that we do based on bone density, but we may limit some of the positions. The therapists may limit some of the positions that they put children in to avoid stress on joints and bones. So the psychosocial impact on caregivers is generally around the acute and persistent emotional stress and distress that they have. They have a child with a sudden loss of function, and generally they've been in the hospital for probably, on an average of about 45 days before they even come to rehabilitation. So parents have been in the hospital a long time. There's delays and there were delays and uncertainties likely about the diagnosis. So we need to be able to provide support for caregivers for coping and adjustment as they grieve this sudden and chronic change in their child's functioning. We have to help the parents to help their child cope and adjust and participate in rehabilitation. And peer support may be beneficial for caregivers, and that can be through the Acute Flaccid Myelitis Association or the Siegel Rare Neuroimmune Association can be referred to. For the child with AFM, a psychosocial impact involves, fear, pain, fatigue, diminished control, and as we said, communication barriers. And this all can manifest in stress behaviors. Children also are affected by anxiety, procedural separation, and generalized anxiety. And this leads to behavioral dysregulation, and again, can lead to variable participation in therapy and care. Siblings may also manifest many of the same issues that the child with AFM has. With anxiety, they also can experience a lot of uncertainty, and this is especially true during the pandemic when siblings have been very limited in coming into the hospital to be able to visit with their siblings. And then they also have a loss of parental attention because parents are spending a lot of time at the hospital. So we need to provide children with opportunities for control through choices and age-appropriate education regarding their diagnosis and their siblings' diagnosis and procedures, distraction and activities to decrease anxiety during procedures and related to separation anxiety. And we need to work to give children skills, train them on skills for relaxation and coping and adjustment, and involve the parents so that they can help their child by giving them cues during the day to use those coping and adjusting skills. Other therapy challenges include flaccid paralysis in one or more limbs or the neck and core. For some children, there's proximal greater than distal weakness, and it's often asymmetric. There's difficulty with communicating pain and communicating wants and needs. Children present with sitting and standing balance impairments. They can quickly develop joint contractures and limitations in head and cervical rotation too, and also develop pretty rapidly. We see the beginnings of scoliosis and joint subluxations, particularly in the shoulders if the upper extremities are affected. So key components of activity-based rehabilitation include weight-bearing, locomotor training, task-specific practice, mass practice, and functional electrical stimulation. Therapists also use other modalities, including working on positioning, orthotics, splinting. They can use aquatic therapy if that's available. Strengthening respiratory muscles and vibration also can be helpful. So weight loading involves the upper and lower extremities, and children should also become comfortable with lying in a prone position, especially those on ventilators, as it can really help with secretion mobilization when they're ill. Children that can't bear weight on their lower extremities can be assisted by the therapist or assisted by bracing or other external supports, such as standers, walkers, and gait trainers. Task-specific practice involves the completion of specific motor tasks to improve motor learning. They should be goal-directed, and they also can be associated with mass practice or repeated repetitions. And the goals for task-specific and mass practice will change as the child grows and develops in what new skills that they're needing to learn. Locomotor gait training is aimed at retraining neural patterns to improve walking and provide specific sensory cues for walking, and it can be completed in a partial body weight support environment over a treadmill with therapy assist. It should also be transitioned to overground locomotor training, And again, therapy assist or with gait trainers or walkers. And locomotor training and all the other modalities that I already talked about, components can be accomplished in the aquatic environment. Functional electrical stimulation is used in conjunction, can be used in conjunction with any or all of the previous components. And it can be useful to strengthen particularly partially denervated muscles, gradually increasing the intensity of the stimulation and a lot of distraction can help kids with AFM who have intact sensation tolerate the sensation of electrical stimulation. The inpatient rehab team then is also working to develop and train the family in a home and community rehabilitation program. So it's really helpful if therapists can discharge the family with a written plan for home rehabilitation and a use of the equipment that they've had in the hospital. And this plan can then be shared with the community therapists that they can assist to locate in the home community who may or may not be very familiar with activity-based therapy. They're also ordering or making recommendations if children are going a long way from our center for home equipment and bracing and orthotics. So common equipment that we're looking at is if a child needs one, as would be a wheelchair or walkers or assistive devices, standing frames, either mobile or glider, bath equipment, and electrical stimulation units are kind of the minimal things that we would make recommendations for. For children who have poor recovery greater than 3 months after onset in either affected limbs or the diaphragm, should be referred to a center experienced in nerve and tendon transfer surgeries as a way of surgically improving strength in weak muscles. And a delay in consideration of nerve transfers could result in a missed window of opportunity as the muscle viability wanes over with extended denervation. And there's been a number of papers presented, published over the last couple of years regarding nerve transfer surgeries. And what has come out is that elbow flexion, surgeries that promote elbow flexion and extension are the most successful, but the success with shoulder abduction is certainly improving. In the lower limbs, there's a paper that presents that shows that that there are some children who prior to their nerve transfer surgery were wheelchair dependent, but with gluteal nerve reconstructions, they have transitioned to ambulation with assistive devices, which all these surgeries can really result in great improvement in function. So the transition to home will involve family training and education. So all throughout the inpatient admission, the therapists and the nurses and psychologists and everybody are providing training for the family. And as we're approaching discharge, we usually like families the caregivers to do a 24-hour in-house sort of dry run. And this way they can get a good idea of what their child's home care is going to be. And they can also see if there's any areas that they need some additional training or practice in. The team will help the family identify community resources for things such as completing home modifications, obtaining home nursing, ordering equipment and supplies, help the family develop a plan for transportation to medical appointments, schedule follow-up appointments with many specialists that will be involved, plan for ongoing rehabilitation, and a plan for managing ongoing psychosocial support in the family. Transition to school is certainly the major transition for children with AFM. It's important for them to get back to school as it provides age-appropriate developmental development through peer interaction, and they get back in a social setting. We need to assist the school professionals and the families in the development of an appropriate IEP or 504 plan. Children may require modifications for the school day, including the length of the school day. They need assistance of a paraprofessional or a nurse during their school days. We help with preparing the educators and nurses, what equipment and supplies will kids need at school, adaptive equipment and assistive technology that can help with access to their educational program. This could involve mobile arm support, standers. Some children may need some type of cervical support to be able to participate in school. And then our team also will help to prepare the peers in the classroom. And they help the children develop a social story that they can use to explain their AFM and how it's affecting them. And they can also, either a professional or sometimes the child chooses to do that presentation to their class so that they understand what has happened with the child. So the first year home, generally families say it's a very challenging time. They're very happy to be home to begin the process of figuring out the new normal, while they're also maintaining hope for ongoing improvement in function. Although they do say that they are always worried that they're not doing enough. Are they doing enough therapy for their affected child? Are they spending enough time with their other children? Are they spending enough time with their spouse? You know, there's just always that worry of, am I doing enough? There's also a delay in obtaining all the equipment that they used in the hospital and they were trained on, including a manual wheelchair. You know, like if children need power wheelchairs or standers, those will have to go through all the insurance process. So parents are fearful that they don't have equipment that they could be using for their child's home rehabilitation or outpatient therapies. Challenges also include coordinating of care. Parents report that if they only had to take care of their child, it would be much easier, but instead they have to be coordinating care. It's difficult to find and maintain qualified home nursing care. They wind up scheduling ongoing appointments and attending ongoing appointments and therapy. Every month you're ordering equipment, you're ordering supplies, dealing with insurance company issues, and then finding and maintaining good therapy, which for some families may involve travel. Peer support, families report, can have positives and can have some negatives. There can be, some drama in peer support, and there also can be an unwhelming amount of information that people are gathering from, different websites or other families and stuff. And in conclusion, the last thing that parents usually tell me is that the only silver lining or saving grace in this whole, awful situation is that they're amazed at how resilient their child is and how well that they are coping and adjusting to this situation. Thank you very much.
Thank you so much, Janet. That was very, very informative. I know I always learn something new whenever I hear you talk. So first I'm going to open the question and answer session to ask Janet. I'm going to ask a medical question first. You mentioned hypercalcemia of immobility, and I know that individuals that work in the field of spinal cord injury and paralysis, dealing with adolescents, are very familiar with this. But how likely it is to occur in children with acute flaccid myelitis related to the paralysis, and how would it manifest? How would we think about it, and how would we treat it?
So hypercalcemia of immobility, usually we see in older children, although we did see it in some of our younger children this time. It occurs in about, I think, 10 to 20% of children with spinal cord injury. and we saw it in just, I think, 2 of our children, and it was manifested in high calcium levels, and also children can have nausea and vomiting and just irritability for unknown reasons, and were found to have the hypercalcemia. And generally it's treated with increasing fluids and diuretics, and we also gave children a dose of pamidronate, which is helpful in keeping calcium in the bone. So that's how we manage that.
Thank you. Yes, sure. So that's so fatigue, irritability, abdominal discomfort, lack of interest in participating in therapy, and usually hypercalcemia does not occur necessarily in the acute ICU, or if it occurs there because of frequent blood testing, it's identified. But in rehab, where we don't usually take a lot of do a lot of blood work, it might go unnoticed. So just raising awareness. Any utility of use of FES, if used, what neurologic level is considered as indication for trial, timing, and duration of use, as well as what is used to measure functional outcomes?
So we will use electrical stimulation starting even in the intensive care unit. The therapists in our intensive care unit start using it. There isn't a specific neurologic level that it can be used with. We use it on any muscle groups that children are not able to move themselves. FES is significantly more challenging in children with AFM because the stimulation levels that you may need to facilitate contraction of the muscle can be the children may not be able to tolerate it. So it's one of the tools that we use, but it may not be the primary tool for children with AFM.
So in your experience, do you apply eSTIM on FES even if there is no clinical response, or is it guided by the muscle contractibility?
I think we do it in both cases if children can be able to tolerate it, but it's and we use it in functional electrical stimulation with cycling and which allows us to stimulate a lot of muscle groups at one time. And then we will also utilize it in muscles that are weak, that we're trying to improve the strength of those muscles.
So I will try to put a reference. There is a paper that was published at the beginning of 2022 in children with acute flaccid myelitis that correlates muscle mass, so preservation or increase in muscle mass with function, and also with bone density. So that might answer a little bit more about this question. I recommend dealing with anxiety and depression years out from diagnosis stemming from IFM. That's a very good question, because I was about to ask you something about this.
Yeah, so I think those are questions that we ask children about and their families about when they come in for rehab appointments. And then if children and families feel like their children are having difficulty with this, then we can refer them to our colleagues in psychology for behavioral psychology. We also, the SRNA, the Siegel Rare Neuroimmune Association also has a camp every summer that is a camp for families, and children with AFM come and they can meet other children that have AFM. So, you know, having children be able to meet other children with AFM. Sometimes, you know, if they're at a big center where they're receiving therapy, they will meet other families and children with AFM. So peer support even for the children can help. So those are things that I think we do for all kids in rehabilitation. Medications, you know, can be helpful also. So referral to psychiatry to look at those things. We have a neuropsychologist on staff at KKI, so he's seen some of these children for us.